Now guys, starting with the local anesthetics. Local anesthetics. Local anesthetic meaning what? Local anesthetic is not local anesthesia, guys. Local anesthetics are the drugs that can be given. Remember guys, local anesthetic are drugs that can be given in local anesthesia, यानी कि a small specific area you are making now. Spinal anesthesia, यानी कि for below umbilicus short duration surgeries. Epidural anesthesia, below umbilicus long duration surgeries, as well as nerve blocks, यानी कि for brachial plexus block and all, you can use this local anesthetics, right? So they are given in local anesthesia, spinal, epidural and nerve blocks, except for general anesthesia. Now guys, local anesthetic, what will they do guys? यानी कि they will basically loss of pain sensation. But how? Where are they acting? Local anesthetics usually act on the nerve terminal by blocking what channels? By blocking the sodium channels. Okay? Now, the form of local anesthetic that enters the nerve to block the sodium channel is what form guys? The non-ionized form enters the nerve terminal, whereas the ionized form of local anesthetics block the sodium channel. Ionized form blocks the sodium channel. Okay, so the main action is blocking the sodium channel. Now guys, these local anesthetics are classified into two categories. What two categories? One category is called as the amino ester category of type of local anesthetic, whereas the other category is called as amino amide. First we'll discuss what are amino esters. Amino esters examples. Remember guys, in amino esters, we are having the drugs called as cocaine, procaine, tetracaine, benzocaine, cocaine, procaine, tetracaine, benzocaine and chlorprocaine. What is common in all these guys? Don't tell me cane is common. No, the common thing over here is what? All these are having one alphabet of I. Okay? Remember guys, look at the spelling of amino esters. Amino ester spelling mein how many alphabet of I is there? One I. If amino ester is having one I, all the drugs in amino ester category will have one I. If you remember this, you can easily remember what are the drugs in amino esters. All drugs will have one I, right? Now guys, a few important points over here. Cocaine was the first introduced local anesthetic. Used for what two surgeries? Used for eye surgery as well as for spinal anesthesia, right? Can you use cocaine IV? Cocaine is never given IV. It should never used IV. Why? Why? Because it causes severe vasoconstriction. Hence avoided IV. Hence it is avoided IV. So these 2 points you have to remember regarding the cocaine. Okay. Next is procaine. Procaine is the safest local anesthetic in malignant hyperthermia. Procaine is the safest local anesthetic in malignant hyperthermia. There is a condition called as malignant hyperthermia which is seen due to triggering of the normal ryanodine receptors that releases calcium and all. Okay. Next, chlorprocaine. Chlorprocaine is the shortest acting local anesthetic. Shortest acting local anesthetic. These three things, these three drugs in amino esters you have to remember. And apart from that, you also need to remember one more thing of amino esters, that amino esters are the local anesthetic that can cause allergic reaction to the patient. When given to the patient, they can cause allergic reaction. Why amino esters can cause allergic reaction? Why? Because normally amino esters are metabolized in the plasma by plasma pseudocholinesterase. But some amino esters are metabolized to, after being metabolized by plasma pseudocholinesterase, they are metabolized to a compound called as PABA, which is what, guys? Para-aminobenzoic acid. So the question that could be asked is, among these local anesthetic which can cause allergic reaction, it is always amino ester. But the question has become a bit more complex. They are now asking, in amino esters, what are the two amino esters that can cause allergic reaction? The amino esters that can cause allergic reaction are P and B. The amino esters starting with the alphabet P and B. You have to remember PABA and you can remember the amino esters causing allergic reaction. P stands for procaine. B stands for benzocaine. They can cause allergic reaction. So that was regarding amino esters. Coming to the next form of local anesthetic, which is called as aminoamide. In aminoamide, remember guys, look at the spelling of aminoamide. In aminoamide, how many I's are there? I can locate 2 I's. So all the drugs of aminoamides will have 2 I's. Starting with what? Lignocaine, also called as lidocaine or xylocaine. Next is bupivacaine. Next is ropivacaine, which is an enantiomer of bupivacaine, which is less potent. Okay? Next is dibucaine. Next is prilocaine. Right? So these are what, guys? These are the aminoamides, right? Now guys, 2 or 3 important things that we need to remember over here is what? Lignocaine. Regarding lignocaine. Lignocaine is an aminoamide, no doubt. Why? Because 2 I's are there. Lignocaine is the most commonly used local anesthetic worldwide. It is the most commonly used local anesthetic worldwide, right? As I am telling, it is most commonly used in worldwide. Why? Because it is having very common uses, guys. The use case of lignocaine is very vast. It is commonly used in IVRA. It is commonly used for many other anesthesia techniques and all. Okay. So lignocaine is commonly used local anesthetic. Why it is commonly used local anesthetic? Why? Because it is used in majority of the anesthesia related techniques and all. Okay. So it is the most commonly used local anesthetic worldwide. It is most commonly used local anesthetic in IVRA. Apart from that, it is the most common local anesthetic to cause malignant hyperthermia also. Malignant hyperthermia also. Right? So these are a few points of lignocaine that we need to remember. Apart from that, you also need to remember the dose of lignocaine, guys. The dose of lignocaine is what? If you are giving plain lignocaine, then it should be given in what dose? Plain lignocaine should be given in a dose of, come on guys, what should be the dose of plain lignocaine? It should be given in a dose of 4.5 mg per kg body weight. But if you are adding lignocaine with adrenaline, then the dose can be 7 mg per kg body weight. No matter if you increase the dose, there won't be chances of toxicity. Why? Because adrenaline will just increase the duration, but it will decrease the toxicity of lignocaine. Right? So guys, anyways, that was regarding the dose of lignocaine. Imagine you remember the dose of plain lignocaine is 4.5, but by mistakenly you have given lignocaine in a dose of 9 mg per kg body weight, plain lignocaine in this dose. Then what will happen? As lignocaine is a neurotoxic drug, as lignocaine produces CNS or neurotoxicity, what you will see in the patient, the first sign of lignocaine toxicity in the patient is perioral numbness. We are discussing about the local anesthetic systemic toxicity, LAST. Okay? First sign is perioral numbness. Patient complains of perioral numbness. If you neglect that perioral numbness, saying the patient that it is normal to have this and that, then slowly what will happen? The patient will land up into tremors. From tremors, he lands up into seizures. From seizures, if you don't manage, the patient will land up into respiratory arrest, ultimately leading to what arrest? Cardiac arrest, sir. Right? So remember, the dose of plain lignocaine is 4.5, and with adrenaline, this is the dose. If at all the patient lands up into local anesthetic systemic toxicity, what is the management of lignocaine toxicity, guys? The management of toxicity is what? If the patient is having seizures, then you give anti-epileptic medication. Anti-epileptic medication. Or if the patient is having what, guys? If the patient is having seizures, you give anti-epileptic. If the patient is having respiratory arrest, the best way to manage the respiratory arrest is by intubate and ventilate the patient. Intubate and ventilate the patient. Meanwhile, you can also give an antidote for any systemic toxicities caused by local anesthetic, which is called as what? 20% of intralipid solution. 20% of intralipid solution can also be given. Okay, this solution is commonly usually used for any systemic toxicities caused by local anesthetic, but it is precisely, or it works very good for bupivacaine toxicity, guys. Okay, so anyways, that was regarding what, guys? That was regarding the lignocaine. Regarding bupivacaine, what we need to remember? Bupivacaine is most commonly used local anesthetic in spinal anesthesia. And what anesthesia, guys? Spinal anesthesia. Why? Why? Because it is longer acting than lignocaine. Okay. But bupivacaine is also the most cardiotoxic local anesthetic. Most cardiotoxic. Whatever things I am writing, these all were asked, guys. Very, very important. Bupivacaine is the most cardiotoxic local anesthetic. Okay. Again, bupivacaine toxicity happens. What we need to do? Intubate, ventilate, and give intralipid solution. If at all cardiac arrest happens, you can give adrenaline. Okay. So that's regarding bupivacaine. Ropivacaine is an enantiomer of bupivacaine. Ropivacaine is a enantiomer of bupivacaine, but this is less potent than bupivacaine. It is less potent than bupivacaine. Next is dibucaine. Regarding dibucaine, guys, what we need to remember? Dibucaine is the longest acting local anesthetic. Dibucaine is the longest acting local anesthetic. Are we using dibucaine for anesthesia, sir? No, sir. Dibucaine is only used for a test which is called as dibucaine number test. Right? Dibucaine number test. Next is what, guys? Prilocaine. Prilocaine is commonly used for surface anesthesia purpose and also used for IVRA. Prilocaine. Prilocaine. It is used for surface anesthesia in the form of Embla cream. Embla cream is eutectic or equal mixture of local anesthetic. Whenever a child is being hospitalized, you can apply an Embla cream and you can put an IV cannula so that the patient does not have the pain of cannulation. Okay? And prilocaine can also be used for IVRA in addition to lignocaine. In addition with lignocaine. Lignocaine is a must-use drug in IVRA. Okay? But prilocaine, remember guys, prilocaine should never be applied to a neonate. Prilocaine application is contraindicated in neonates. Why? Due to the risk of methemoglobinemia. That's regarding what, guys? That's regarding prilocaine. And that was regarding the local anesthetics. Okay, guys? So you need to remember local anesthetic, amino esters, aminoamides, and mechanism of action of local anesthetics. Now, guys, starting with this topic called as regional anesthesia. In regional anesthesia, we divide this regional anesthesia into two halves. One is called as central neuraxial block, other is called as peripheral nerve block. Central neuraxial block once again consists of what things, guys? Central neuraxial block consists of spinal anesthesia, epidural anesthesia, caudal anesthesia, that is commonly used in pediatric cases in the caudal epidural space. Okay? And last is what, guys? Saddle anesthesia. Saddle is a form of spinal anesthesia. Normally in spinal, after giving spinal anesthesia, you make the patient lie down. Whereas in saddle anesthesia, after giving the spinal, you make the patient sit for some time. Okay? This is commonly used for perianal surgeries and all. Okay. So anyway, central neuraxial means it consists of these four things. Whereas peripheral nerve block, it consists of brachial plexus block, stellate ganglion block, brachial plexus block is there, stellate ganglion block is there, and then there is femoral plexus block. Okay, those are the things that comes under peripheral nerve block. Anyways, guys, we are discussing about the regional anesthesia. In regional, first we'll start with the central neuraxial block. In central neuraxial block, the first thing that comes to my mind is we need to discuss about spinal anesthesia. Spinal anesthesia. Come on, guys. The indication of spinal anesthesia is very simple. It is used for below umbilicus short duration surgeries. Below umbilicus short duration surgery. Appendicectomy, LSCS, hernia, hydrocele, all can be done within 2 to 3 hours. You can go for spinal anesthesia. Okay, how many hours? 2 to 3 hours of duration. Okay. Now, we know the indication of spinal. What we need to know, remember guys, in spinal anesthesia, you make the patient sit, then you choose a space, introduce a needle. The space most commonly chosen is by locating a Tuffier's line. Tuffier's line. Tuffier's line is a landmark to locate the site for giving spinal anesthesia. So continuing with this topic of regional anesthesia. The regional anesthesia is further divided into central neuraxial block and peripheral nerve block. Central neuraxial block consists of what? What are the things that you see in central neuraxial block? In central neuraxial block, we are having spinal anesthesia, we are having epidural anesthesia, we are having saddle block or saddle anesthesia, and then we are having caudal anesthesia, right? These are the four things that you see in central neuraxial block. Whereas in peripheral nerve block, we see the nerve blocks involving the different plexus of nerve. Example, brachial plexus block, stellate ganglion block, femoral plexus block or ankle block. So anyways guys, we need to discuss about the central neuraxial block first. In central neuraxial block, we were discussing about spinal anesthesia. Spinal anesthesia. Now, for spinal anesthesia, what we need to remember guys? Spinal anesthesia, what we need to remember? We need to remember the indication of spinal. What is the indication of spinal anesthesia? For what surgeries you go for spinal? It is given for below umbilicus short duration surgeries. Below umbilicus short duration surgery such as appendicectomy, LSCS, appendectomy. You can go for spinal. There are many surgeries guys. Okay, below umbilicus short duration surgery, you go for spinal anesthesia. Now, apart from indication, we also need to remember something about the procedure and something about the complications that you see in spinal anesthesia, right? Now, regarding the procedure of spinal, remember spinal anesthesia is not given on the spinal cord, but spinal anesthesia is given in the space where spinal cord is present. Okay, but it is always given below the spinal cord. Imagine this is the spinal cord. Spinal anesthesia is given below the spinal cord. So remember guys, spinal anesthesia when you give to the patient, what should be the position? The patient should be in a sitting position or lateral position. Okay. Apart from position, you need to remember you have to clean the site. You have to locate the site. Where are you giving the spinal anesthesia, guys? For spinal anesthesia, for giving spinal anesthesia, where will you introduce your needle? What is the site for giving spinal anesthesia? Again, that is important. The site for giving spinal anesthesia, it is the L3 to L5 space. L3 to L5 space, right? In that L3 to L5 space, you need to remember L4, L5 is very easily identified space. Why L4, L5 is easily identified? Why? Because there is a landmark to identify that space which is called as Tuffier's line. Tuffier's line. Tuffier's line is nothing but you keep your hands on the highest point of the iliac crest and thumbs like this. Okay, you stand at the back of the patient, keep your hands and thumbs like this. An imaginary line can be created between your thumbs that is called as Tuffier's line. That indicates that you are in the L4, L5 space. So once you have located the Tuffier's line, what is the next thing that we need to do? You have to introduce the needle. Okay? You have to introduce the needle. The needle commonly used in spinal anesthesia is dura separating needle. A thin bore dura separating needle. Now, the most important thing in spinal anesthesia is what? As you are introducing the needle from the skin, what are the layers pierced? This is very important, guys. Layers pierced in spinal anesthesia. The first layer to be pierced is the skin. After skin, it is the subcutaneous tissue. After the subcutaneous tissue, it is the supraspinous ligament. Supraspinous ligament. After supraspinous ligament, it is the intraspinous or interspinous, or it is also infraspinous ligament. After this, there is ligamentum flavum. Ligamentum flavum. Now guys, ligamentum flavum is what? Ligamentum flavum is the toughest ligament or the hardest ligament. Toughest or the hardest ligament to be pierced. Once ligamentum flavum is pierced, what you will see, as it is the toughest ligament, once you pierce the ligamentum flavum, on piercing of it, you will feel a snap or sudden loss of resistance. Sudden loss of resistance is felt on piercing of ligamentum flavum, as it is the toughest ligament. Okay? But it doesn't mean that we are stopping over here. Once you pierce the ligamentum flavum, the next structure that you encounter is dura. Once you puncture the dura, there will be a membrane called as arachnoid. And once that arachnoid is punctured, you will be in the subarachnoid space that has CSF. Subarachnoid space that has what? That has the CSF. So basically the last layer to be pierced in spinal anesthesia is the arachnoid. Okay? So last layer and the toughest ligament, these are the important, and the order. The order of structures pierced is also very important that you need to remember. So once you are in the subarachnoid space, what we do? We aspirate some CSF back into the syringe. Aspiration of CSF back into the syringe is called as barbotage. We aspirate some 1 to 2, or basically not 1 to 2, we aspirate some 0.5 to 1 ml of CSF back into syringe, which is called as what? Which is called as barbotage. And then we inject the local anesthetic. Then we inject the local anesthetic into the CSF. Okay? Into the CSF. Now, what local anesthetic will we inject? The most commonly used local anesthetic in spinal anesthesia, we have already discussed bupivacaine. Bupivacaine, right? Second most commonly used local anesthetic in spinal. Remember, most commonly used local anesthetic in spinal, it is bupivacaine. Second common is what? Second most common is what? It is lignocaine. Now guys, with this bupivacaine and lignocaine, in order to increase the duration, you can also add some additive. Most commonly for spinal anesthesia, the additive that we commonly use is opioids. Opioids are used as additive for spinal anesthesia. Normally for all local anesthetics, the additive commonly used is a vasopressor called as adrenaline. But for spinal, we use opioids. Okay? In opioids, what are the opioids that we commonly use, guys? We use fentanyl. We used morphine, fentanyl. Sufentanil is there. But one opioid is avoided, guys. Sufentanil, alfentanil can also be given. The opioid that is avoided in spinal anesthesia is what? The opioid that is avoided in spinal anesthesia is remifentanil. Why remifentanil is avoided? As it contains neurotoxic preservative. It has neurotoxic preservative. Hence, remifentanil is avoided in what anesthesia? In spinal anesthesia. Okay. Now, what are the side effects of using this opioid? There have been a question regarding the side effect. Side effect of spinal opioids are the patient might have respiratory depression due to usage of this opioid. The patient might have nausea, vomiting, and patient might also have pruritus. But the question was not about all these. Which is the most common? I have already highlighted the most common side effect of using this opioid is pruritus. Spinal opioid it is the most common side effect of using spinal opioid is pruritus. Okay. That was regarding the spinal anesthesia procedure. Now guys, immediately after giving spinal anesthesia, one has to be prepared. One has to be always prepared himself. What has to be prepared? He has to be prepared to face the complications. But how will you be prepared to face the complications? Once you are ready with your emergency drug tray. So basically, what I do is, sometimes in some cases, before giving spinal, I prepare an emergency drug tray. In some cases, immediately after giving spinal, I prepare an emergency drug tray. But the mandatory thing that I do is, I always prepare this drug tray, whether before spinal or whether just immediately after giving spinal. Why it is mandatory to prepare this emergency drug tray and what I am keeping in this emergency drug tray? In this emergency drug tray, I keep phenylephrine, I keep atropine, I keep pethidine, I keep a laryngoscope, ET tube and adrenaline. Why am I keeping these drugs? Why? Because I know that the patient might land up into some complications immediately after giving spinal anesthesia. Now, what complications the patient might land up into? These complications of spinal anesthesia are further divided into two types. One is the intraoperative complications, other is the postoperative complications. In the intraoperative complication, the most common intraoperative complication that the patient might suffer from is hypotension. Very, very important, guys. Hypotension is the most common complication. Apart from hypotension, what are the other complications the patient might have? Patient might have bradycardia. Apart from bradycardia, the patient might also have other complications such as shivering. Other complications apart from bradycardia and shivering is what, guys? The patient might have high spinal anesthesia. The patient might have total spinal anesthesia. Due to this, the patient might also have respiratory depression leading to cardiac arrest. Cardiac arrest. We are going from the most common to least common, guys. Cardiac arrest is the least common side effect of spinal, but one has to be ready for it. These are the intra-op complications. Post-operative complications, yani ki immediately after surgery, what is the most common post-operative complication? The most common post-operative complication of spinal anesthesia is what, guys? It is acute retention of urine. Acute urinary retention. That is the most common post-op complication of spinal anesthesia. Next complication that could occur is what? Headache. Nowadays, headache is not at all seen. Why? Because we are using a thin bore needle. Previously, we used to use a thick bore needle that was causing headache. Nowadays, headache is not seen. The next complication that you see in spinal anesthesia is what? Apart from headache, the patient might also have what? In the post-operative period, the patient might also have cranial nerve damage. Which cranial nerve? Sixth cranial nerve. Sixth nerve. But again, if the patient is having headache, then only he'll have it. Okay? Why? Because due to headache is seen due to loss of CSF. As the CSF is being lost, there would be a traction developing on the brain that could compress the sixth cranial nerve. Okay? Next, apart from that, what are the other complications that you see in the post-operative period? Headache, acute retention of urine, sixth cranial nerve palsy. These are the common complications that could occur. But the most common post-op is acute retention of urine. There are a few complications such as spinal epidural abscess, but that's not that common. Now, headache is the most, in the intraoperative complication, the most common intraoperative complication is hypotension. So, hypotension, why will it develop? Why? Because spinal anesthesia produces sympathetic blockade. That's why patient will have hypotension. There are two reasons. One, spinal is producing sympathetic blockade. The other reason is what, guys? In spinal anesthesia, there is blockage of the adrenal gland that can cause hypotension. So, if the patient develops hypotension in spinal, what is the next drug that we need to give? Again, for the management of hypotension, you go to the emergency drug tray, you will find that drug in the first column. What is that drug, guys? Phenylephrine. Phenylephrine is a drug of choice for hypotension in spinal anesthesia. Hypotension in spinal anesthesia. The second best drug is ephedrine. If phenylephrine is not there, the second best drug is what, guys? Ephedrine. But again, ephedrine, if a pregnant lady is there who's posted for cesarean and immediately after spinal she develops hypotension, you can't give ephedrine. Why? Because ephedrine can cause fetal acidosis. So ephedrine is the second best drug. The best drug is phenylephrine for hypotension. The next complication that could occur in spinal anesthesia is bradycardia. The patient's heart rate decreases due to the blockage of the cardio accelerator fibers. The patient's heart rate will decrease. Now guys, how will you manage this bradycardia? For managing this bradycardia, again we go to the emergency drug tray. We find it in the second column. What is the drug that we give, guys, over here? Atropine. Atropine is used in the management of bradycardia. Bradycardia. Okay. Next, guys, what is the next complication? Shivering. As the patient is having vasodilation in the lower limb blood vessels get dilated. So what will happen? All the blood from the upper part goes and settles to the bottom. The patient will lose out heat, leading to shivering. The management of shivering in spinal anesthesia, go to the emergency drug tray, you will find it. It is pethidine. Pethidine is used in the management of shivering. But one precaution of pethidine is what? If you want to use pethidine, you also need to ask the patient whether he is on monoamine oxidase inhibitor or not. If he is on monoamine oxidase inhibitor and then you give pethidine, then what will happen? What will happen, guys? It will lead to severe sympathetic reaction. Severe sympathetic reaction. So anyways, pethidine should not be used when patient is using monoamine oxidase inhibitor. That's why we are stopping monoamine oxidase inhibitor for 3 weeks. Next complication of spinal is high spinal. High spinal means what? High spinal anesthesia is when the achieved level of the drug is higher than the desired level. You wanted the drug to act till T6, but your drug has gone or ascended up till T4. When the achieved level is higher than the desired level, it is called as high spinal. High spinal is characterized by two things together. What two things, guys? Hypo and brady together. Hypotension and bradycardia together is seen in high spinal. Okay. But again, for high spinal, we don't have to be worried because in the emergency drug tray, if hypotension occurs, phenylephrine is there. If brady occurs, atropine is there. Management is done. Next complication is total spinal. When do you call it as total spinal? When the drug has ascended into the intracranial segment. Intracranial segment. Movement of the drug that you have given inside the CSF, when it goes into the intracranial segment, it will cause total spinal. In total spinal, you will see the features of high spinal width. You will see respiratory depression, and if not managed, cardiac arrest can also occur. So how will you manage total spinal? Again, sir, for managing all intraoperative complications, we are having this drug tray ready. As the patient in total spinal is having hypo and brady, you are giving this. As the patient is having respiratory depression, you take your laryngoscope and put an endotracheal tube so that the patient does not have any difficulty in breathing. If his airway is secured, then will he develop cardiac arrest? No. But in some unfortunate patient, if still they develop cardiac arrest, then there is a drug of choice for cardiac arrest, that is adrenaline in the emergency drug. Okay. So these are the intraoperative complications of spinal anesthesia. Coming to the post-op complication, guys, the most common we have already discussed. Acute retention of urine due to blockage of sacral segments. You will see this, okay? Next is headache. Headache can be seen, guys. Headache can be seen. It's not at all common. Nowadays it has become a rare complication. But if headache occurs in spinal anesthesia, the best management of headache in spinal is what, guys? Conservative line of management. What is meant by conservative line of management? Conservative line of management means what? You just give patient coffee, you give NSAIDs, you give IV fluids. Okay? Coffee, NSAIDs, IV fluids are given in conservative. If that conservative fails, then the definitive management or the last resort, definitive management for headache and spinal is what, guys? Epidural blood patch. Epidural blood patch. That's regarding what? That is regarding the headache management in spinal anesthesia. So guys, these were the things that we need to know about spinal anesthesia, right? Now, apart from that, you also need to remember there are a few contraindications of spinal, in which conditions spinal anesthesia should not be given. Now, coming towards the contraindications of spinal anesthesia. In some conditions, spinal anesthesia should not be given, even though patient might be posted for below umbilicus short duration surgery. Short duration surgery. Even though patient is posted for some short duration surgery such as appendicectomy or any other surgery, but in some conditions spinal is contraindicated. What conditions, guys? If the patient is posted for below umbilicus short duration surgery and he is having shock, can you give spinal anesthesia? Even though the main indication of spinal is this, but can you give spinal anesthesia in shock? No, sir. Absolutely no. Why in spinal anesthesia? Why in shock spinal is contraindicated? Why? Because shock means patient's BP is already low. Patient is having a BP of 80/50. If you give spinal, the most common complication of spinal is what? It causes hypotension. Already hypotensive. What will happen to this BP? It becomes 40/20. That can cause sudden circulatory collapse also. Right? So in shock, spinal is contraindicated. Apart from that, spinal is also contraindicated in raised intracranial pressure. If the intracranial pressure of the patient is raised, you can't give spinal. If you give spinal, what will happen? The CSF will jet out. There might be herniation of meninges. So spinal is contraindicated in raised intracranial pressure. Next, spinal anesthesia is also contraindicated in local site infection. If the patient is having infection at the local site, spinal anesthesia is contraindicated. Infection at the local site means what, guys? If the patient is having skin infection involving the L3 to L5 space, will you introduce the needle? If the patient is having any abscess of the wall or abscess of the skin of L3, L5, no. So local site infection is a contraindication. Apart from that, if the patient is refusing, patient refusal, that is also a contraindication. Patient refusal is also a contraindication. Apart from that, there are some more contraindications such as patient having fixed cardiac output lesions and patient having a low platelet count or any coagulopathies. Those are all contraindications. But these are the common ones, guys. And remember, raised intracranial pressure, local site infection and patient refusal, these are the absolute contraindications of spine. In these conditions, spinal anesthesia should never be given. Okay, even though he might be posted for below umbilicus short duration. Absolute indication of spinal is below umbilicus short duration surgery. But if the patient is having underlying shock and these all conditions, then spinal is contraindicated. Okay, that was regarding the spinal anesthesia, guys. Right now, next coming to what? Next coming to epidural anesthesia. Epidural anesthesia. Now, guys, epidural anesthesia, once again, we need to remember what? We need to remember the indication of epidural. What is the indication of epidural? Epidural anesthesia is commonly used for what purpose, guys? The most common and the most important indication is what? It is used for below umbilicus long duration surgery. Long duration surgery, such as total hip replacement or total knee replacement. You use epidural anesthesia. Why your epidural anesthesia is acting long? Why your spinal anesthesia acts for a short time? In spinal, that is a single shot technique. You give the drug in the CSF, procedure is done. Whereas in epidural, after you reach the epidural space, this is the needle that you use in epidural, guys. So once your needle is in the epidural space, then you place a catheter. One end of the catheter will be in the space. One end of catheter will be in epidural space. Other end will be outside. Other end is lying outside. The other end which is lying outside, through that other end, you can give the top-up doses. You can give the top-up doses of the drug. Yani ki after 2 hours, yani ki surgical time 2 hours is done. After 2 hours, the patient is complaining of pain on the surgical site and the surgery is still continued. You are having a continuous catheter. Through that catheter, give the top-up dose. Again, for next 2 hours, patient won't have pain. Okay. So epidural, you are using a long-term catheter. Okay. In epidural anesthesia, guys, the needle that we use, this is the needle that we commonly use. The needle that we use in epidural anesthesia is 2 Hoy's epidural needle. 2 Hoy's 18 gauze epidural needle. The length of the needle is 9 to 10 centimeters. Okay. 2 Hoy's epidural needle. Right. What else we need to remember about this epidural anesthesia? Apart from this, we also need to remember that the structures that are pierced in epidural is same like spinal only. Skin, next subcutaneous tissue, next supraspinous ligament, next infra or interspinous ligament, next ligamentum flavum. Here in epidural, ligamentum flavum. Once you pierce the ligamentum flavum, there will be dura. Will you puncture the dura? No, sir. Epidural space, the last layer that you pierce is what? Ligamentum flavum. Once you feel the snap or loss of resistance, you stop. Your needle is in this space. What is in this space? Epidural space is the space between the ligamentum flavum and the dura. Once your needle reaches the dura, you stop there and place the epidural catheter. So last layer to be pierced in epidural is ligamentum flavum. Okay, so that's regarding the epidural anesthesia. And remember guys, the drug that you give in epidural anesthesia is what guys? Bupivacaine and lignocaine. But will you give the drug in same dose and same concentration guys? No sir. We decrease the concentration of the drug and give it to the patient. Okay? Now guys, we have discussed that epidural is commonly used for below umbilicus long duration surgery. There are two more indications guys. Before just epidural anesthesia can also be used for painless labor. Painless labor. Okay? For painless labor, we place an epidural catheter, and after placing the catheter, we give this drug called as bupivacaine. And in what concentration we give guys? We give bupivacaine in a very low concentration, that is 0.0625 to 0.125%. Right? You give the drug in this concentration. When you give the drug in this concentration, it will only cause sensory block, while the motor activity will be intact. Motor activity will be intact. Okay. So this is called as painless labor concept. Painless labor. So this was regarding what guys? This was regarding the epidural anesthesia. Okay. By placing a catheter inside the space, we achieve this. Okay. So guys, after spinal anesthesia, there are two more things in central neuraxial block that we need to discuss. One is the caudal anesthesia, other is the saddle anesthesia. Caudal anesthesia means what? It is basically the anesthesia which is given in pediatric cases at the level of sacral hiatus, at the level of sacral hiatus. It is given at caudal epidural space. It is the caudal epidural space. Saddle anesthesia meaning what? After giving spinal, you don't make the patient lie down. You make the patient sit. After spinal anesthesia, we make the patient sit. Normally after spinal, you make the patient lie down so that the drug that you are given in the L3, L4 slowly ascends up. But if the patient is posted for perineal surgery and again you want the effect on the buttocks only, so what we need to do? Just make the patient sit after giving spinal. What will happen? The drug that you have given in the L3, L4 space, that drug will accumulate in this area and will have a good concentric block in this area only. Okay? And it bars the other, it is leaving the other parts intact, or it is not affecting the other parts. Only this area is made numb. That is called as saddle anesthesia. So after giving spinal anesthesia, we make the patient sit for 8 minutes so that the drug affects at the bottom. Okay, that is used for the surgeries of the perineal area or like anal fissure surgery, fistula surgery, and this hemorrhoid surgery. Okay, this was regarding the central neuraxial block. Coming to the peripheral nerve blocks. In the peripheral nerve blocks, we'll start with the first nerve block, that is called as brachial plexus block. Brachial plexus block. Guys, remember, brachial plexus is formed by what? Brachial plexus is formed by C5 till T1. C5, C6, C7, C8 and T1. Brachial plexus is responsible for the sensations and the motor activity of the upper limb. Now guys, if you want to block the brachial plexus, basically there should be an indication. If the patient is having fracture of the hand or fracture of any part of the hand, you can go for brachial plexus block. But how will you block the brachial plexus? This brachial plexus, in order to reach the needle into the brachial plexus or in order to reach the brachial plexus, there are three routes. There are three routes to reach the brachial plexus. The first route is called as interscalene route. The second route is called as supraclavicular route. And the third route is called as axillary route. These are the common routes, guys. Okay. Now just look over here. Interscalene means you are introducing the needle between the anterior and middle scalene. But remember, interscalene, with this interscalene, only proximal routes are blocked. Only proximal routes are blocked. When I am talking about proximal routes, what routes we are discussing? Only C5, C6, C7 is blocked. As only proximal routes are blocked, this is commonly used, or interscalene approach is commonly used. Interscalene is most commonly used for proximal arm surgeries. Proximal arm surgeries. Whereas, what are the routes which are not blocked at all? It is C8 and T1. C8 and T1 are not blocked. As C8 and T1 are not blocked, what is the nerve that is being spared? The nerve that is being spared in this interscalene approach is the ulnar nerve. Ulnar nerve is spared. Okay, ulnar nerve is spared. And sometimes while going towards the while inserting the needle towards while inserting the needle from the interscalene approach, sometimes what could happen? Sometimes you might damage a nerve. The nerve that could be damaged in interscalene approach is what, guys? It is the phrenic nerve. Hence, it can cause diaphragmatic palsy. That is interscalene approach. Next approach of brachial plexus is what? Supraclavicular. The second approach is supraclavicular. The beauty of this approach is what? With supraclavicular approach, all the roots are blocked. All the roots are blocked. Hence, it is used for almost all surgeries of the upper limb. But this approach, supraclavicular approach, is the best approach, but it comes with a complication. What complication can be encountered, guys? The complication that could be encountered is, just look over here. As we are introducing the needle just above the clavicle to find the brachial plexus, sometimes the needle might touch the pleura and hit the pleura, leading to a complication. So remember, guys, the most severe complication of interscalene approach, most severe complication of supraclavicular approach. Supraclavicular approach is pneumothorax. Pneumothorax. Okay? Interscalene approach we have done, and supraclavicular we have done. Coming to the axillary approach. The third approach is axillary. Axillary approach means you are introducing the needle from the axilla to find the brachial plexus. Okay? This is the most distal approach used for hand and forearm surgeries. Used for hand and forearm surgeries. Okay? The nerve that is being spayed over here. What is the nerve that is being spayed over here? Again, an important MCQ. The nerve that is being spayed over here is what? The musculocutaneous nerve. musculocutaneous nerve. That is the nerve that is being spayed in axillary approach. That was regarding the brachial plexus. Okay. Now coming to this, which is called as stellate ganglion block. Come on guys, stellate ganglion block. What we need to remember? First of all, stellate ganglion block is indicated for what? It is indicated for Raynaud disease. It is indicated for the management of, like, the Raynaud disease is not managed by some peripheral vasodilators. You can go for stellate ganglion block. Okay? It can be used for drug-induced vasospasm or catheter-induced vasospasm. What is stellate ganglion responsible for? Stellate ganglion is responsible for sympathetic activity. Sympathetic activity of face, neck and upper limb. Okay, that is stellate ganglion responsible for sympathetic activity of the face, neck and upper limb, right? Now, we have discussed the indications. Raynaud disease, we go for stellate ganglion catheter induced. Where is stellate ganglion present? Stellate ganglion is present anterior to the border of C6 vertebrae, which is where you find a tubercle called as Chesapeake's tubercle. Chesapeake's tubercle. Okay? That is also spelled, some anesthetists spell it as, or some anesthetists pronounce it as Chesapeake's tubercle. Anywhere, any which ways, guys. Okay? Now, what you need to remember, once you block the stellate ganglion, what signs you see in a patient in a successful stellate ganglion block. Once stellate ganglion is successfully blocked, the signs of successful stellate ganglion block is what? First is Horner's syndrome, achievement of Horner's syndrome. Okay, that is ptosis, meiosis, anhydrosis. Second is Gutman's sign. What is Gutman's sign? Vasodilation of nasal mucosa. Vasodilation of nasal mucosa. Third sign that you see is called as Muller's sign. What is Muller's sign? Muller's sign is nothing but vasodilation of tympanic membrane. Vasodilation of tympanic membrane. These are the signs of achievement of a stellate ganglion block. Next coming to what, guys? Next coming to the surface anesthetic cream, which is commonly used nowadays as, which is called as EMLA. What is the full form of EMLA? EMLA is equal, or it is also called as eutectic mixture of local anesthetic. Eutectic mixture of local anesthetic. Eutectic or equal means what? 2.5% lignocaine plus 2.5% prilocaine forms 5% EMLA. It forms 5% EMLA. Okay. Now guys, EMLA is usually used in pediatric cases where the child is not allowing you to put an IV cannula. You can go for EMLA cream and all. But there is a contraindication to this EMLA. What contraindication? EMLA should not be applied in neonates. Why, sir? Why? Because as you apply EMLA in neonates, first of all, it is not needed. Second, if you apply, what will happen? Lignocaine and prilocaine, which is present in EMLA, they will get absorbed through the neonatal skin. If lignocaine gets absorbed, no problem. But if prilocaine gets absorbed, what will happen, guys? Due to absorbing of this prilocaine, the patient will develop, or patient will land up into methemoglobinemia. Methemoglobinemia. That is the most common side effect associated with EMLA used in whom? In neonates. Methemoglobinemia. Okay. So that's regarding what, guys? That is regarding the EMLA 3. Okay, right. Next coming to general anesthesia, guys. Next, starting with this topic of general anesthesia. As we are starting with this topic of general anesthesia is given for what surgeries? General anesthesia is given for what surgeries? Any surgeries which is done above the level of umbilicus. Above the level of umbilicus. It could be including the heart, the major surgeries such as heart surgery, brain surgery, lung surgery, take any thoracic surgery. You can go for general anesthesia. And any laparoscopic surgery also. Any laparoscopic, whether it is below or above. Why? Because if at all below umbilicus laparoscopic surgery is there, instead of spinal you go for general. Why? Because in laparoscopic surgeries you are introducing a gas called as carbon dioxide, which will cause much irritation. If at all laparoscopic surgery is done in the spinal anesthesia, it will cause much irritation to the patient. Patient will have shoulder pain and all. Okay, so that's why for all laparoscopic surgeries we go for general anesthesia, right? So general anesthesia is the only anesthesia technique where the patient is made fully unconscious. Patient is unconscious. In all other anesthesia techniques, the patient is conscious. There are some components of general anesthesia. The components or the main aims of general anesthesia. What should be our aim in general anesthesia? The patient should have amnesia. The patient should have analgesia. Patient should have hypnosis. And he should have paralysis so that he does not move during surgery. These are the components of general anesthesia which can be achieved by using IV agents, by using inhalational agents, by using muscle relaxants. So, in general anesthesia, will you only use one agent and give general anesthesia? No, sir. We are using a combination of IV agent, inhalational agent, muscle relaxant. As we are using a combination of these three drugs in general anesthesia to achieve our aims, hence general anesthesia is also called as balanced anesthesia technique. Balanced anesthesia. Balanced anesthesia means what? Balanced anesthesia means multiple drugs given in a titrated form to achieve the effect. Are you just dependent on one drug? No. Multiple drugs given in titrated form is called as balanced anesthesia, and this balanced anesthesia concept was introduced by John Lundy. John Lundy. Okay? John Lundy introduced this balanced anesthesia technique. Right. Now, we are discussing about the phases of general anesthesia. How in practicality, how we give general anesthesia. Okay? General anesthesia can be given in 4 phases. General anesthesia effect can be achieved in 4 phases. The first phase is called as pre-oxygenation. The second phase of general anesthesia is called as induction. The third phase is called as maintenance phase. And the last phase is called as reversal or recovery phase. Basically, you are making the patient conscious and you are making the patient unconscious. Basically, just cut down the 5 seconds, right? Basically, in general anesthesia, you make the patient unconscious and वापस से you make him conscious. In these, making the patient unconscious to conscious, these are the 4 stages the patient has to undergo. First is pre-oxygenation, second induction, third maintenance, fourth is reversal. Now guys, general anesthesia is usually, we anesthetists usually compare general anesthesia like flying an aeroplane. The first phase of general anesthesia is what guys? Pre-oxygenation. In the pre-oxygenation phase, we pre-oxygenate the patient for 3 to 5 minutes with 100% of oxygen. 100% of oxygen using a bag mask. But what if the patient is full stomach? If the patient is full stomach, we don't go for bag mask, we go for a normal mask. We'll discuss that later. So anyways, the first phase is the pre-oxygenation. The second phase in general anesthesia in the induction. Induction phase means what? Make the patient unconscious. Make the patient unconscious. The patient should not be conscious. Make him unconscious. In the induction phase, remember pre-oxygenation is done. Second is the induction phase. In the induction phase, guys, what should be your aim? First aim is you make the patient unconscious. How will you make the patient unconscious? You make the patient unconscious by giving IV induction agent. Or in children, they can be made unconscious by using inhalational agents. Okay, first aim is make the patient unconscious. The second aim in the induction phase is what? Make the muscles relax. Once the patient is unconscious, make the muscles relax by giving what? Short-acting muscle relaxant. Short-acting muscle relaxant. Always remember guys, before intubation, only a short-acting muscle relaxant. The third aim, remember, once you make the patient unconscious and make his muscles relax, patient is equal to a dead body. He is like a dead body. Okay? But if you want your patient to breathe and all, after making his muscles relax, the third aim you have to achieve. What is the third aim, guys? You have to intubate and ventilate. Intubate and ventilate the patient. Okay, that is your aim in the induction phase. The next phase of general anesthesia is called as what, guys? The next phase of general anesthesia is called as the maintenance phase of anesthesia. The maintenance phase of general anesthesia. Just look over here, guys. We have just started the flight. The takeoff phase is the induction phase. Once the flight is taken off, the next phase of the flight will be what? It has to maintain itself in the mid-air. The next phase of the flight is what, guys? The maintenance phase. The next phase of general anesthesia is the maintenance phase. The last phase of general anesthesia as well as flight is what? The reversal or the landing phase. Okay. So guys, we are discussing about the maintenance phase. So in the maintenance phase of general anesthesia, what should be your aim, guys? The first aim should be what? Remember, the same aims of the induction will be continued. But instead of make, you will write what? In the maintenance phase, your aim is what? Maintain the patient unconscious. Second aim is what? Maintain muscle relaxation. And third aim is what? Maintain ventilation. How will you maintain the patient unconscious? By using inhalational agent. How will you maintain muscle relaxation? By using long-acting muscle relaxant. And how will you maintain the ventilation? Just connect the ventilator and ventilation will be maintained. That is in the maintenance phase. Now maintenance phase is done. Surgery is done. Now we are in the reversal phase. We need to make the patient वापस से conscious. So we need to go into the reversal or the landing phase. In the landing or the reversal phase, what should be your aim, guys? In the landing or the reversal phase, in the landing or the reversal phase, your aim should be what? Make the patient conscious. How will you make the patient conscious? How was he maintained unconscious? By inhalational agents. So, stop inhalational agents. Flight is about to land. The patient is about to make conscious. Second is what? The muscles which were relaxed. Now you have to make the muscles contract. How will you make the muscles contract? By giving a reversal agent against muscle relaxant. What is the reversal agent against muscle relaxant? Neostigmine, Sugamadex. ठीक है? Neostigmine, Sugamadex, Pyridostigmine, Edrophonium, L-cysteine. L-cysteine is commonly used for reversal of Gantacurium effect. Gantacurium muscle relaxant. So these are the muscle relaxants. These are the reversal agent. But commonly used is what, guys? Neostigmine. But if you give neostigmine, what will happen? If you give neostigmine against for the reversal, what will happen? Patient will have bradycardia. So what we give, guys, with neostigmine, we give either glycopyrrolate or either atropine. Okay. The third aim in the reversal phase is what, guys? The third aim is what? Extubate the patient. Extubate. Once the patient is muscles are contracting and he is conscious, you have to extubate. Extubate means what? The tube which was inside, no? Remove the endotracheal tube. That is called as extubation. Okay. But before extubation, you need to make sure that he is adequately reversed. What are the signs of adequate reversal? There are many signs of adequate reversal. But guys, the sign that you commonly see on the bedside, the best bedside sign is what? You tell the patient to lift his head for 5 seconds. If the patient is having sustained head lift for more than 5 seconds, then it is the best bedside sign that indicates the patient is adequately reversed. Okay? But the best clinical test, the clinical test that could detect the patient has been reversed or not is what, guys? It is looking at the train of 4 ratio. The train of 4 ratio more than 0.9 indicates the patient has been reversed. We'll discuss the train of 4 ratio later. So these are the signs of adequate reversal. So those were the phases of what anesthesia, guys? General anesthesia. We have discussed the balance anesthesia. Now guys, just look over here. Now in the induction, remember we have discussed pre-oxygenation, we have discussed induction. Now guys, in the induction phase, what should be your aim? To make the patient unconscious, to make the muscles relax and then to intubate. How will you make the patient unconscious? Induction can be done. Yani the patient can be made unconscious. The first aim of the induction phase is to make the patient unconscious. Make the patient unconscious. It can be made unconscious by either using opioid or non-opioid medication. In opioid, you can use fentanyl, you can use remifentanil, you can use sufentanil. Okay? You can use fentanyl, remifentanil and sufentanil. These are opioid medication. But guys, remember, which medications are commonly used to make the patient unconscious during unconscious for surgery? It is always the non-opioid. Then when or what is the reason of using opioid? Opioid medication is used in the patients who's having severe reduction in the ejection fraction. Patient is having severe cardiorespiratory compromise, but he wants to undergo a surgery. In those cases, you can make him unconscious by using opioids such as fentanyl, remifentanil and sufentanil. In this, remember the most potent opioid is what? it is always sufentanil. The ultra short acting opioid is which one, guys? Ultra short acting is remifentanil. Why remifentanil is ultra short acting? Why? Because remifentanil is metabolized by RBC esterases. RBC esterases. So anyways, guys, we know the indication of opioid. Coming to non-opioid. In non-opioid, you are having what, guys? In non-opioid, you are having barbiturates and non-barbiturate medications. So guys, barbiturate, what is the barbiturate that we commonly use in anesthesia? Or what are the IV induction agent that belongs to barbiturate category? Sodium thiopentone and methotrexate. Sodium thiopentone and what, guys? Sodium thiopentone and methotrexate. These are barbiturates. What are non-barbiturates, guys? The non-barbiturates include the propofol, ethomidate, and ketamine. Propofol, ethomidate, and ketamine. So basically, guys, now leave the opioid, concentrate on the non-opioid because these are the commonly used. Thiopentone, methotrexate, propofol, ethomidate, and ketamine. Okay. Now, guys, the non-barbiturates we need to discuss. In the non-barbiturates, just look over here, guys. There is sodium thiopentone, there is propofol, there is ethomidate, and there is ketamine. Now, remember, sodium thiopentone, propofol, and ethomidate, these are usually producing unconsciousness, or these are commonly used induction agents that produces unconsciousness by acting on what receptors? They act on GABA receptor. Whereas ketamine makes the patient unconscious by acting on NMDA receptors. It is an NMDA receptor blocker. Okay? Whereas thiopentone, propofol, ethomidate acts on GABA. Now guys, we'll discuss the IV induction agents starting with sodium thiopentone. Sodium thiopentone, we have to remember the introductions and the effects. Remember introduction, sodium thiopentone is what? It is a yellow amorphous powder and it is regarded as a ultra short acting barbiturate. Ultra short acting barbiturate. Why it is an ultra short acting barbiturate, guys? Why? Because sodium thiopentone is having rapid redistribution. It is having what, guys? Rapid redistribution. Hence it is ultra short acting. Okay. Now next, what else we need to remember? Sodium thiopentone, whenever you prepare it, you never mix with Ringer's lactate. It is never mixed or prepared with Ringer's lactate. Why? Because if you mix it, it will form crystals. Right? Now, what is the thing that we need to remember is, what is the effect of sodium thiopentone? Effect of sodium thiopentone on various systems. Various systems means there is CNS, there is CVS. Remember top to bottom, guys. CNS, CVS, respiratory, muscle, and pain system or analgesic system. Okay? Pain system or analgesic system. I used to remember one line of sodium thiopentone and all MCQs used to be covered in that. Remember, there are MCQs being asked on the effect. Effect of sodium thiopentone on various systems is what? Sodium thiopentone is the best friend of CNS. Best friend of CNS. And enemy of rest all the systems. And it is the enemy of all other systems. Now guys, As it is the best friend of CNS, what will it do? Best friend of CNS means, will it cause damage to the CNS or will it be CNS protective? It will be CNS protective. Best friend will cause damage or it will be protective? Protective. So sodium thiopentone is CNS protective. How? Sodium thiopentone decreases the intracranial pressure. Hence it is used as an IV induction agent of choice. IV induction agent of choice for head injury and neurosurgery. Head injury and neurosurgery. Second is what, guys? Sodium thiopentone decreases the risk of epilepsy, or it is basically having anti-epileptic property. Sodium thiopentone is having anti-epileptic property. Hence, it can be used as an IV induction agent of choice for epileptic patients. Third, sodium thiopentone can be used for narcoanalysis. Truth test. Okay? Sodium thiopentone can be used. So, hence it is regarded as a, remember, as it is the best friend of CNS, 3 good qualities on CNS. 3 best qualities on CNS. As it is the best friend, it is an IV induction agent of neurosurgery, anti-epileptic, as well as what? Narcoanalysis can be used. Next, as it is an enemy of all other systems, enemy of cardiovascular means what? It is basically contraindicated in shock and ischemic heart disease. Why? Because it decreases the BP. Remember, sodium thiopentone effect on CVS is what? It decreases BP and increases heart rate. It causes hypo and tachycardia. Okay. Sodium thiopentone is an enemy of respiratory, hence contraindicated in what? Bronchial asthma. As sodium thiopentone releases histamine, causes bronchoconstriction, contraindicated in asthma. Sodium thiopentone has no effect on muscle. Sodium thiopentone, as it is an enemy of analgesic system, there is no analgesia. It has no analgesic effect. Instead, it causes pain. Okay, that is regarding sodium thiopentone. So if you remember this one line, that sodium thiopentone is the best friend of CNS and enemy of all other systems, you can remember the good points and you can also remember the contraindications. That is the main points of sodium thiopentone. Next is what, guys? Next is, apart from that, you also need to remember sodium thiopentone is having anti-thyroid properties. It is having good anti-thyroid properties. Okay. Next IV induction agent is called as propofol. Now again in propofol, what we need to remember, guys, propofol is a milky white solution which is made up of egg, lecithin and soy. Lecithin acts as an emulsifying agent. Okay, egg, lecithin and soy. Right? Now next, what else we need to remember about sodium thiopentone, this propofol? Propofol is having a short elimination T-half of less than 2 hours. As it is having short elimination T-half of less than 2 hours, this property makes it as a drug of choice or IV induction agent of choice for daycare surgery. Now guys, effects of propofol on various systems. If you remember thiopentone, propofol effects are similar, guys. Similar. But propofol effect, what is the difference that we need to remember over here is, propofol is just a friend of CNS. Propofol is not a best friend, guys. It is a just friend. Just friend means what? One good quality. One good quality means what? Propofol also decreases ICP. Hence, it is the second best agent. Rest all qualities of propofol and thiopentone are same only. Rest all the effects on CVS, respiratory, same only. Just you need to remember a small differentiating feature in propofol and thiopentone is, remember thiopentone was causing hypotension and tachycardia. propofol will cause hypo and bradycardia. Hypo and bradycardia, right? Now, regarding propofol, what else we need to remember? The main important points of propofol that we need to remember is what, guys? Where is propofol used as an IV induction agent of choice? Propofol used as an IV induction agent of choice. Propofol is the most commonly used IV induction. Why it is most commonly used IV induction agent? Why? Because it is used most commonly for many problems, guys. So I was discussing about propofol. Propofol is used as an IV induction agent of choice. It is a very common IV induction agent. It is commonly used for many things, but it is used as an IV induction agent of choice for what cases, guys? Daycare surgery. Why, sir, in daycare surgery propofol? Why? Because it's having a short elimination T-half. Apart from daycare surgery, propofol is also used as an IV induction agent of choice for patients suffering with porphyria, acute intermittent porphyria. In acute intermittent porphyria, many of the IV induction agents are contraindicated, especially thiopentone. But propofol is used as an IV induction agent of choice. Next, propofol is used as an IV induction agent of choice for LMA insertion. What is LMA insertion, guys? Laryngeal mask insertion, you use propofol, right? Next, propofol is used as an IV induction agent of choice in TIVA. TIVA. What is TIVA, guys? Total intravenous anesthesia is called as TIVA. Total intravenous anesthesia means what? It is an anesthesia which is given without using any inhalational agents. Okay. Next, propofol is the only IV induction agent that is preventing nausea and vomiting, and again it is having antiemetic properties. Antiemetic property. Apart from that, what else we need to remember about propofol? Propofol is an IV induction agent used for liver surgeries or liver disorder. Patient is having liver disorder, the IV induction agent of choice that could be used is propofol. Propofol is used as an IV induction agent of choice for malignant hyperthermia. So you can just look over here, guys. There is a list of drug conditions where propofol is used as an IV induction agent. So guys, in the exam, if you don't remember the list, remember thiopentone is having specific indications. Ketamine has specific, but propofol has many indications. So it is the most commonly used IV induction agent, guys. Okay. Next. But propofol is coming with a side effect. What is the side effect of propofol? If you give propofol as a long-term infusion, the patient might land up into a syndrome that is called as propofol infusion syndrome. Propofol infusion syndrome. Propofol infusion syndrome is characterized by what? The triad of three things. In propofol infusion syndrome, we see skeletal and cardiomyopathy. Skeletal and cardiomyopathy can happen. Metabolic acidosis can happen, and green color urine. The patient might have green color urine. When you use propofol for more than 48 hours, especially in children, right? Then this children might land up into this syndrome called as propofol infusion syndrome. Okay. Coming to the next drug, which is called as ketamine. We'll discuss ethambutol later. First, we'll discuss ketamine. Ketamine introduction is what? Ketamine works on NMDA receptor. Remember, the IV induction agents working on GABA are thiopentone, propofol, ethambutol. Ketamine works on NMDA receptor. It is an NMDA receptor blocker. Ketamine is an NMDA receptor blocker, okay, or NMDA receptor antagonist. Now, regarding ketamine, or regarding the effects of ketamine. Remember, if you remember the effects of sodium thiopentone, you can easily remember the effect of ketamine. What was the effect of sodium thiopentone? Best friend of CNS, enemy of others. Whereas ketamine is what, guys? Ketamine is, remember what are the systems we need to cover? CNS, CVS, respiratory, muscle, analgesia. Ketamine is what to the CNS and what to the other systems? Ketamine is the worst enemy of CNS and friend of all other systems. Now with this we can easily come to know what it is showing, what MCQs can be covered. Worst enemy, it will have contraindications to the CNS. Friend means it will be used as an IV induction agent of choice for problem of these systems. Okay. Contraindication. Why it is regarded as the worst enemy of CNS? Why? Because ketamine increases the intracranial pressure, hence contraindicated in head injury and neurosurgery. Ketamine not only increases ICP, also increases IOP, hence contraindicated in glaucoma. Ketamine is causing epilepsy, hence contraindicated in epileptic patients. When you give ketamine to the patient will have hallucination, delusions and all. Okay? As ketamine causes hallucination, it is contraindicated in schizophrenic patients. Right. It is contraindicated in schizophrenic patient. Okay. That is regarding the ketamine. Okay. And it is a friend of all other systems. It is an IV induction agent of choice for shock as well as cyanotic heart diseases, but contraindicated in ischemic heart disease. Why? Because ischemic heart disease patient cannot tolerate extreme changes in the blood pressure and heart rate. Next, it is an IV induction agent of choice for respiratory problems such as bronchial asthma. Why? Because it causes bronchodilation. It causes increase in the muscle tone and it is the only IV induction agent that is having analgesic property. And again, ketamine is a painless IV induction agent. Okay. So, it is a friend of these systems, enemy of this system. That we need to remember. That's regarding ketamine. Coming to the last drug, which is called as what? Ethomidate. Ethomidate is also a milky white solution, which is an imidazole derivative. It is an imidazole derivative. Regarding ethomidate, what we need to remember, ethomidate is the most cardio-stable IV induction agent. It is the most cardio-stable, meaning what? Thiopentone will cause hypo and tachy. Okay. Whereas propofol will cause hypotension and bradycardia. Ketamine will cause hypertension and tachycardia. All of the IV induction agents are either decreasing or either increasing the BP and all. Right? They are causing some changes and all. Ethomidate is the only IV induction agent that neither decreases nor increases. That maintains the BP and pulse rate normally. So as it is the most cardio-stable, this is the most commonly used IV induction agent in cardiac patients. But it is having some side effect. What is the side effect of this ethomidate? On long-term infusion of ethomidate, it will cause what? It will cause adrenal suppression. Adrenal suppression. This is very, very important, guys. Right? Long-term use of ethomidate can cause adrenal suppression and deterioration of the patient's health. So, ethomidate is having this side effect. But the good effect is a cardio-stable IV induction agent. Those are the points of IV induction agents that we need to remember. Right? Before going to the muscle relaxant, we'll also discuss methotrexate. Guys, remember, methotrexate, is it used for other induction? Is it used for the normal cases? No. Methotrexate is a barbiturate type of IV induction agent which is commonly used for ECT. What is ECT? Electroconvulsive therapy. Electroconvulsive therapy. That is regarding what, guys? Methotrexate. Right? Next, guys. After IV induction agents, now we'll discuss about the muscle relaxants. While we are discussing about the muscle relaxants, what we need to discuss? Muscle relaxants, they are of two types. Okay. First of all, guys, remember, whenever you give the muscle relaxant drug, where will the muscle relaxant drug act? Where will the muscle relaxant drug act? Imagine this is the nerve and here is the muscle. Where is the muscle relaxant will act? The muscle relaxant will work on the junction between the nerve and the muscle. What is this junction called as? NMJ, the neuromuscular junction. They work on the neuromuscular junction on the NM receptors, right? The nicotinic muscle receptors, it will work and block those receptors, or the acetylcholine receptors or the NM receptors are blocked. Hence, muscle relaxation occurs. So remember, guys, there are two categories of muscle relaxant. One is called as a depolarizing muscle relaxant. Another is called as a non-depolarizing muscle relaxant. Non-depolarizing muscle relaxant. So one is called as a depolarizing, other is called as a non-depolarizing muscle relaxant. In depolarizing muscle relaxant, only one drug that we need to remember is choline. One more drug is there, decamethonium, which is not used. In non-depolarizing, there are many drugs, guys. There are many muscle relaxants that we need to remember. After giving the muscle relaxant, sometimes this muscle relaxant effect might not be that adequate. In order to check the adequacy of the muscle relaxant, we use a ratio called as train of 4 ratio. Train of 4 ratio. Train of 4 ratio means what? We use this device. We keep the electrodes on the muscle called as adductor pollicis, and then we stimulate the nerve. What is the nerve that is stimulated? The ulnar nerve is stimulated. Yani we give 4 twitches and then we see what is the response. So remember, in train of 4, the most common nerve that is used is ulnar nerve. Just look over here, guys. In train of 4, after applying the electrodes, you give 4 twitches in 2 seconds gap. Okay. Each twitch is of 0.2 hertz. After giving the first twitch, you take 2 seconds gap and give the second twitch. Okay. Then you give the third twitch. You will get this thing. Then you give the fourth twitch. You will get this response. If you are getting this response, remember, this is the first twitch, this is the second, this is the third, this is the fourth. Okay? If you are getting this response, that means what? Either the muscles has not been relaxed, or either you have used a depolarizing muscle relaxant. Remember, guys, in depolarizing muscle relaxant, what will happen is, when you give a depolarizing muscle relaxant, all twitches, the twitch height will be same only. The first to the last. If you take a ratio of T4 by T1, all the heights will be same. So remember this, after giving a depolarizing muscle relaxant, in the first 10 seconds, you take this train of 4, you are getting this response. In the next 10 seconds, you will get this response. You will get this response. Is there a difference? Yes, sir. The twitch height is decreasing. As the twitch height is decreasing, but is it fading? Is the twitch height fading? No. Is the ratio decreasing? No. The T4 to T1 by ratio is 1 in depolarizing muscle relaxant. If you give depolarizing. Whereas if you give a non-depolarizing muscle relaxant, what will happen, guys? Just look over here. After giving this non-depolarizing muscle relaxant, after 1 minute, if you take this strain of 4 ratio, the first twitch height will come like this. The second twitch height will come like this. The third twitch height will come like this. The fourth twitch height will come like this. So, what do you see, guys? You are seeing a fading effect. A fading effect. So, train of 4 ratio in the case of non-depolarizing muscle relaxation, the T4 to T1 or train of 4 ratio will be less than 0.4 in cases of non-depolarizing. That is the train of 4 ratio, guys. Okay. So, anyways, we are discussing about muscle relaxant, and as I was telling you, there are 2 categories of muscle relaxant. One category is called as what, guys? The depolarizing. Other is the non-depolarizing. In the depolarizing category, we are having what? We are having scoline. Whereas in non-depolarizing muscle relaxant category, they are further classified into the steroidal and the benzyl isoquinoloniums. Okay? The steroidal and benzyl isoquinoloniums. Right? So, first came the benzyl isoquinoloniums. In that, they are divided. Benzyl isoquinoloniums are usually the muscle relaxant ending with the term curiums. Example, atracurium, cisatracurium, mivacurium, doxacurium. Whereas in curoniums, what are the examples, guys? Pancuronium, vecuronium, rockcuronium. Pancuronium, vecuronium and rockcuronium. Right? Now in the curiums, where atracurium, cisatracurium. But before steroidal and benzyl isoquinoloniums came, in the curiums categories, the first introduced muscle relaxant was D-tuberculare. The first introduced was what, guys? D-tuberculare. D-tuberculare. Right? So everyone look over here. The first introduced muscle relaxant was D-tuberculare. When it was introduced, there was a guy called as Harold Griffith. He gave this D-tuberculare to the patient. The muscles were relaxed. At the same time, they noticed what? They noticed the patient is having some allergic reaction. The patient is having severe hypotension. Hence, it is not used. The side effect of D-tuberculare is what? It causes severe hypotension. Hence, D-tuberculare is not used. Then, the surgeons, they requested the guy who introduced D-tuberculare, Harold Griffith, saying that your discovery is good, but we won't use it. Instead of D-tuberculare, use any other muscle relaxant. So, D-tuberculare was not used. Instead of D-tuberculare, Harold Griffith did not come up with other muscle relaxant. There were some other anesthetists. They came with the other muscle relaxant, which was called as atracurium. In the benzyl isoquinolonium, it was atracurium that was introduced, guys. The second introduced was atracurium. When atracurium came into the market, it was a wonder muscle relaxant. Why? Because it was neither metabolized in the liver, nor it was being excreted through the kidneys. It was going a magical metabolism called as Hoffman elimination or Hoffman degradation. Hence, it was used for liver failure patient as well as renal failure patient. Yani it was a muscle relaxant of choice. It was used for all cases, but muscle relaxant of choice. But guys, remember this was having side effect. It was muscle relaxant of choice for hepatic and renal failure. But this atracurium was also having some side effects. What were the side effects of atracurium? Atracurium was causing histamine release, and it was forming a compound called as laudanosine that causes seizures. When you give atracurium for long term, patient will have laudanosine being formed. So what the surgeons told, atracurium discovery is also good, but still these two side effects are seen. Rectify this side effect. So the next muscle relaxant that came into the market for rectification of atracurium mistake was, the next muscle relaxant was cis-atracurium. Cis-atracurium is basically the isomer of atracurium, which is more potent than atracurium. Where is cis-atracurium metabolized? Same place, guys, by Hoffman degradation or Hoffman elimination. Now guys, you guys tell me, in hepatic and renal failure, remember this was the muscle relaxant. Which is the muscle relaxant of choice nowadays? The muscle relaxant of choice nowadays is the muscle relaxant which is free from side effects. What were the two side effects of atracurium? Histamine and laudanosine. Where was it seen with cis-atracurium? No, sir. Negligible amount was seen. Hence, it is the muscle relaxant of choice for hepatic as well as renal failure. Next, after cis-atracurium, the anesthetist thought their work is done, but it was not. Why? Because there were two group of people or two group of surgeons who came to the anesthetist and told that, sir, we want a muscle relaxant that usually works for daycare surgeries or short duration surgery. What surgery? Daycare surgery or short duration surgery. Short duration surgery. Okay? So, the next muscle relaxant that came into the market was what, guys? It was mevaccurium. Mevaccurium is the shortest acting non-depolarizing muscle relaxant. More shortened than mevaccurium is gantacurium, but still studies are going on it. That's why we don't take it as the shortest. So shortest is what, guys? Mevaccurium. Used for what surgeries? Used for daycare surgery. Next group of surgeons told that we want a drug we want a muscle relaxant that acts for a longer time. So next introduced was doxycurium. Doxycurium is the longest acting muscle relaxant. Longest acting muscle relaxant. Working for how many minutes, guys? Working for more than 120 minutes. It is the most potent as well as the most toxic also. Most potent as well as most toxic. It is producing toxicities of multiple systems, not only one, multiple system. Hence, doxycurium is not used. But is the query solved? The longest acting muscle relaxant was doxycurium. But we are only not using it. So, instead of doxa, some other drug has to be used. The next introduced was, after doxycurium was what, guys? It was pancuronium. Pancuronium is the second longest acting muscle relaxant which works for 90 to 120 minutes. Almost similar effect of what, guys? Doxycurium, yes or no? Right? It can work for 90 to 120 minutes. But guys, pancuronium, whenever anyone is asking you about pancuronium, pan starts with P. If you add a line to this P, it becomes R. So whenever anyone is asking you about pancuronium, your answer should be R, R, R. R means what, guys? R means rate. Whenever you give pancuronium, the patient's BP and patient's pulse rate increases. Hence, it is the muscle relaxant of choice in shock. It is a muscle relaxant of choice in shock. Second R of pancuronium is what, guys? Recovery. How's the recovery with pancuronium? As it is having a long duration of action, the recovery is delayed. The patient will be having delayed recovery. The third R of pancuronium is what? Renal. As pancuronium is having renal excretion, it is having maximum renal excretion. It is contraindicated in renal failure. 3 MCQs of panchronium covered if you remember the RRR of panchronium. Okay. The next introduced muscle relaxant is what, guys? Vecuronium. Vecuronium. Remember, guys, we are discussing about the muscle relaxant. The 7th muscle relaxant that was introduced was vecuronium. Just look over here. I used to write vecuronium like this. V of vecuronium looks like heart. Hence, vecuronium is the cardiostable muscle relaxant. Vecuronium is the most cardiostable. Come on, guys. Cardiostable meaning what? It is a muscle relaxant that has no effect on the BP and pulse rate. And like a BP and pulse rate are totally normal. Okay? But with this vecuronium, what else we need to remember? It is a cardiostable, used in cardiac diseases. Apart from that, what else we need to remember? Vecuronium is having biliary excretion. Hence, it is contraindicated in patients who are having obstructive jaundice. That is regarding vecuronium. Rocuronium, I used to remember it as a painful rock star. Painful rock star. It's a painful rock star. Why it is regarded as a rock star? Why? Because, guys, whenever you call rock star to any concert, he comes and he performs and he goes to the other concert very fast. So rocuronium is a rock star. Why? Because it is the fastest acting non-depolarizing muscle relaxant. It is the fastest acting non-depolarizing muscle relaxant. Okay. And it is most painful also. Most painful here, it is a painful muscle relaxant. All muscle relaxant does not produce pain during injection, but rocuronium will produce pain during injection. This rocuronium is commonly used for RSI, rapid sequence induction. Normally in rapid sequence induction, you give a fast acting muscle relaxant called as scoline. But if scoline is not available, you can also go with rocuronium. Rocuronium is commonly used for rapid sequence induction. Now, so as we have completed the muscle relaxants, now we'll discuss which are the muscle relaxants which will release histamine. The muscle relaxants that releases histamine are D-tubocurare, that causes maximum release of histamine. Mevacurium also releases histamine. Scoline also releases histamine. And atracurium also releases histamine. These are the muscle relaxants that releases histamine. Guys, remember, if they release histamine, these muscle relaxants can cause allergic reactions also. Right? In the anesthesia, if the patient is during general anesthesia, if the patient has any allergic reaction, the most common cause of the allergic reaction in general anesthesia patient, or the maximum incidence of allergic reaction in anesthesia patients, is seen with muscle relaxants. Next, followed by latex products. Latex products can also cause allergy, but more maximum it is seen with muscle relaxants that can cause allergic reaction. Okay. Now, guys, coming to the next muscle relaxant, which is called as scoline. Scoline, other name is what? Succinylcholine or suxamethonium. It is very much similar to acetylcholine only, guys. Okay. Scoline is succinylcholine or suxamethonium, which is a depolarizing muscle relaxant. Right? It is the fastest and the shortest acting muscle relaxant. It is the shortest as well as the fastest acting. Shortest and fastest in overall category. In non-depolarizing, the shortest is Meva. In non-depolarizing, the fastest is rocuronium. Whereas in shortest and fastest in overall category is scoline. Why? Because it usually works in 30 to 45 seconds and The duration of its action is for 3 to 8 minutes. Okay. Now, where is the choline metabolized? Choline is metabolized in the plasma by plasma pseudocholinesterase. Plasma pseudocholinesterase. Right? If the patient is having deficiency of pseudocholinesterase, then the patient will have what? Then the patient will land up into a condition called as choline apnea. Choline apnea, even after giving choline, after 8 minutes the patient should recover. If the patient does not recover, he will land up into choline apnea. That choline apnea can be easily diagnosed by a test called as Dibukane number test that detects the atypical pseudocholinesterase. Dibukane number test detects atypical pseudocholinesterase. Atypical pseudocholinesterase. Okay, that's regarding the choline. Okay, that's regarding the metabolism of choline and all. Okay, now guys, remember choline is a depolarizing muscle relaxant. Depolarizing muscle relaxant means what? Whenever you give choline to any patient, what will choline do? Choline will, remember guys, normally depolarization will cause muscle contraction. As choline is a depolarizing muscle relaxant, just look over here. Whenever you give choline to the patient, in the initial few seconds, what will happen? It will cause depolarization. Then it will cause hyperpolarization. Due to that, the muscle membrane then becomes what? What will happen to the muscle membrane? Then the depolarization is gone. Then the depolarization is gone, and then the muscles relax. So initially, due to depolarization and hyperpolarization, what will happen to the muscles? Initially, in 10 to 15 seconds, the muscles of the patient will contract. The muscles will contract. And then slowly, as depolarization is gone, then the muscles will relax. As the muscles are contracting in the initial phase of giving choline, due to this muscle contraction is called as fasciculation. This muscle contraction appearance on the patient is called as fasciculation. Due to this fasciculation, in the post-operative period, the most common side effect of succinylcholine use is muscle soreness. Due to what, guys? Due to fasciculation, the patient will have muscle soreness. Second most common side effect due to fasciculation, the patient will have hyperkalemia. Due to the fasciculation, due to the rapid contraction, the potassium from the muscle has gone into the blood, leads to hyperkalemia. Hence, choline is avoided in already hyperkalemic person. Choline is contraindicated in already hyperkalemic person, such as renal disease or tetanus or burns. Choline should not be given. The third side effect, we are discussing about the side effects of choline. The third side effect is the patient will have bradycardia and increased intracranial tension. The last side effect of choline is what, guys? Malignant hyperthermia. Very, very important, guys. Malignant hyperthermia is the most dreadful complication of choline or dreadful side effect of choline. What is malignant hyperthermia? What is malignant hyperthermia, guys? What is the definition of malignant hyperthermia? Okay? Malignant hyperthermia is abnormally high temperature with sustained muscle contraction. Sustained muscle contraction. This malignant hyperthermia is seen due to what? Malignant hyperthermia is seen commonly in autosomal dominant patients where due to triggering of abnormal, due to triggering of abnormal ryanodine receptor, you will see what? You will see release of calcium. As the calcium is being released, what will happen? The muscle starts to contract, or there might be muscle spasm. Starting in what muscle? Starting in the masseter muscle. Thereby the whole body gets involved. Whole body gets involved. Okay. So that's regarding what, guys? Malignant hyperthermia. My question to you is the scoline causing malignant hyperthermia? No. In anesthesia, there are many things that can cause malignant hyperthermia. In local anesthetic, the most common local anesthetic causing malignant hyperthermia is lignocaine. In muscle relaxant, it is choline causing malignant hyperthermia. In inhalational agents, almost all inhalational agents can cause malignant hyperthermia, but maximum incidence of malignant hyperthermia is seen with halothane. These are triggers of malignant hyperthermia. Triggers of malignant hyperthermia. Okay. Next guys. The safest local anesthetic. Remember, the most common is lignocaine. The safest is procaine. So anyways, that was regarding the malignant hyperthermia. The treatment of choice for malignant hyperthermia is dantrolene sodium. IV dantrolene sodium has to be given. That's regarding what, guys? That's regarding the scoline and the side effects associated with scoline. Okay. So we have discussed the non-depolarizing and depolarizing muscle relaxants. Right. Now, guys, coming to inhalational agents. We have discussed the IV induction agents. We have discussed the muscle relaxants. Coming to inhalational agents. Inhalational agents, when we go into the stages of anesthesia, where we have discussed the pre-oxygenation, induction, maintenance. Remember, inhalational agents are used for two purposes. Inhalational agents are used for induction purpose only in children. Why? Because in children, giving IV induction agent is difficult. Why? Because IV induction agent should be given with IV cannula. The child is not allowing you to put an IV cannula, you can't give IV. So in children, the inhalational agents are used for induction purpose. But the main role of inhalational agent is what, guys? They are used for the maintenance of anesthesia. They are used for maintenance of anesthesia, right? These inhalational agents work on two principles. What two principles they work on? The principle of MAC and the principle of blood gas partition coefficient. MAC and blood gas partition coefficient. MAC meaning what? Minimal alveolar concentration of inhalational agent required to produce no response. Required to produce no response to any painful stimuli in at least 50% patients. In at least 50% patients. Okay, that is MAC. Right? MAC is an indicator of potency. MAC indicates potency of the inhalational agents. Okay? MAC indicates potency. But remember, MAC is always inversely proportional to potency. MAC is always inversely proportional to potency. What is inversely proportional to potency means? Look over here. Any agent that is having high MAC value, that will be low potent. Low potent. And low MAC value will be high potent. Okay, MAC is an indicator of potency of inhalational agents. Right? Now guys, regarding MAC. Before going to blood gas coefficient, first we will discuss a few things regarding MAC. There are few MAC values given for few inhalational agents. Okay? So we'll rate the MAC values. So inhalational agents, I told you, right? MAC indicates the potency. Now I'm writing what? The most to least potent inhalational agent. Most potent means what? It will be having high MAC or low MAC. Most potent means low MAC. So the most potent is having low MAC value is what, guys? Methoxyfluorine. The most potent inhalational agent having a low MAC value is methoxyfluorine, having a MAC value of 0.16. Next is halothane, having a MAC value of 0.75. Next is isoflurane. Next is sevoflurane. Next is desflurane, having a MAC value of 6. Right? Desflurane having a MAC value of 6. These are the MAC values that we need to remember. Right? The most potent is what, guys? Methoxyfluorine, having a MAC value of this. So you need to remember, guys, a mnemonic for it. HISD. This is the mnemonic for most potent to least potent. Most potent to least potent. Right? If you take this mnemonic in a reciprocate manner, such as if you write the mnemonic DSIH. This is the mnemonic for what? This is the mnemonic for blood gas partition coefficient. Yani ke, the agent that is having a speed onset, speed recovery. So this is the mnemonic. DSIH is the mnemonic for the agent that is having a speed onset, speed recovery to the agent which is having slow onset and slow recovery. Right, guys? So HISD is the mnemonic for for most potent to least potent. Okay. In that most potent, remember, guys, instead of HISD, you can remember MHISD. MHISD, if you remember, the most potent will be what? Methoxyfluorine. Right. So that's regarding the MAC and potency. Now coming to blood gas partition coefficient. What is blood gas partition coefficient, guys? Blood gas partition coefficient is the indicator of speed of onset and recovery. It's the indicator of speed of onset and recovery. Right? Basically, if the agent is, remember, guys, blood gas coefficient indicates the speed of onset and recovery. But blood gas coefficient is also inversely proportional to it. Yani ke any agent that is having high blood gas coefficient, it will be slow onset and slow recovery. Whereas any agent that is having low blood gas coefficient, it will be fast onset and fast recovery. Fast onset and fast recovery. Right? Blood gas coefficient meaning what? How much amount of inhalational agent is staying in the blood and how much amount is going into the brain. Any inhalational agent that is having high blood gas meaning what? That is highly staying in the blood. Low blood gas meaning what? That amount of inhalational agent that stays in the blood is very low. Most of that reaches the CNS. Okay. So blood gas coefficient indicates the speed of onset as well as recovery. So I told you guys, for blood gas coefficient, what we need to remember, DSIH, you have to remember. Okay? Remember, HISD is for the most potent to least potent. And this is for what, guys? This is the speed onset to slow onset, right? So over here, D stands for what? Same. Desflurane. S is sevoflurane. I is isoflurane. H is halothane. But here also you need to write a small x over here. That indicates X is for xenon, which is having a blood gas coefficient of 0.14. Next, desflurane is having a blood gas coefficient of 0.42. Halothane is having a blood gas coefficient which is very high and all. Right? And here also remember guys, methoxyflurane is there. DSH, remember, guys, remember DSHIM you have to remember. Here you are remembering MHISD, no? You have to remember DSIHM. M stands for methoxyflurane. Methoxyflurane. Methoxyflurane is having a blood gas coefficient of 16%. Yani ke it is having a high blood gas coefficient. The low blood gas coefficient is seen with xenon, but again guys, xenon is not used nowadays as an inhalational agent. Xenon is an inert gas, we are not using xenon nowadays. Okay? So you have to remember the low blood gas coefficient is seen with desflurane. Low blood gas. As low and high are in front of you, what you need to remember is what guys? Remember, desflurane, low blood gas means fast onset or slow onset? It will be fast onset and fast recovery, hence used for daycare surgery. Whereas methoxyflurane is having slow onset. Methoxyflurane has slow onset, right? So this is regarding the blood gas coefficient. What else we need to remember is, what is the effect of inhalational agents on various systems? Now again, you don't have to remember all, just remember the main points. Effects of inhalational agents on various systems. Okay, when we are talking about various systems, we are talking about the central nervous system, we are talking about the respiratory system, we are talking about the cardiovascular, we are talking about the muscle, and the last system is analgesia. Analgesic system. Right? So what we need to remember with this is, basically, for CNS and CVS problems in any person, the most commonly used inhalational agent is isoflurane. Isoflurane. For CNS and CVS, we use isoflurane. Whereas for respiratory as well as muscle, respiratory and muscle, most commonly, basically for respiratory disorders or the inhalation having good muscle relaxation or muscle relaxant effect, is halothane. Halothane. Even though halothane causes, remember, what does it do to the respiratory system? It causes bronchodilation. But even though it is causing bronchodilation, nowadays the best agent for any respiratory disorder patient and best inhalational agent for a person who is suffering with any respiratory disorder is sevoflurane. Sevoflurane. Okay? I'll tell you the reason later. Next, in the summary we are discussing. Okay? CNS, CVS we have discussed. Respiratory muscle we have discussed. We are left out with what? Analgesia. For analgesia or the inhalational agent having a good analgesic effect is what guys? It is nitrous and trilene. Trilene. Trilene is producing maximum analgesia. It produces maximum analgesia. Okay. Now, if you remember the summary of the effects, remember for CNS and CVS it is halothane, CNS and CVS it is isoflurane, respiratory and muscle it is halothane, right? Now guys, what we need to cover about it, we have to cover a few inhalational agents, okay? Starting with the first inhalational agent which is called as halothane. If someone asks you about halothane, your immediate answer should be what guys? If someone asks you about halothane, the immediate answer should be halothane starts with H, sir. So the answer should be what? 4 H's of halothane. 4 H's of halothane. What are the 4 H's of halothane? All 4 are MCQs of halothane. Halothane is an inhalational agent that produces hyperthermia. What hyperthermia, sir? Malignant hyperthermia. Malignant hyperthermia can be seen due to many other many other agents in anesthesia, but in the inhalational agent, it is halothane that causes malignant hyperthermia. Second H is what? Heart disease. Halothane is contraindicated. Halothane is contraindicated in heart disease. Why, sir? Why? Because halothane produces arrhythmias. Apart from that, halothane produces hypotension and bradycardia. Hypo and bradycardia. The third H of halothane is what, guys? On repeated use of halothane, the patient might land up into a condition called as halothane-induced hepatitis. Halothane-induced hepatitis. Hence, halothane is avoided in continuous infusion. Or basically, on long-term use. Long-term use means what? 2 months back, patient had a surgery under general anesthesia and we use halothane. Can we use halothane in the same patient? No. Repeated use can cause hepatitis. Last is what, guys? Halothane has 3 maximums. What 3 maximum, guys? The first maximum is what? Halothane has maximum bronchodilation. Okay? Second maximum is what, guys? It has maximum muscle relaxation. And third maximum is what? It has maximum metabolism in liver. As it is having maximum metabolism in liver, we don't use halothane repeatedly in the same patient. Why? Because it can cause hepatitis. So these 4 heads of halothane we have to remember. We have to remember the 4 heads of halothane. Now, the next inhalational agent that we need to discuss is isoflurane. Isoflurane. Now guys, what we need to remember about isoflurane? Isoflurane is most commonly used inhalational agent in cardiac diseases as well as, come on guys, in cardiac as well as CNS diseases. Head injury, neurosurgery, use isoflurane. Any heart problems, use isoflurane. Even though iso is not the best one for cardiac patient. The best inhalational agent for cardiac patients, is desflurane. But we won't choose it. Why? Because desflurane is usually stored in a vaporizer that is very costly. And it is also an airway irritant. That's why we don't use desflurane. So remember, in cardiac patients, we use what? We are using in cardiac patient isoflurane. Even though there is a side effect of isoflurane that is called as coronary steal phenomena. Isoflurane causes coronary steal phenomena. Right? We have discussed coronary steal phenomena in the detailed video and all. Okay. So coronary steal phenomena, but again it is proven only in animal studies, guys. Okay. So that's regarding what? Isoflurane. Now, apart from isoflurane, what else we need to remember? The next inhalational agent is sevoflurane. Come on, guys. Sevoflurane summary. What we need to write? Sevoflurane is the inhalational agent used for induction purpose. Induction purpose in children. Guys, I told you children can be made unconscious by using what? Inhalational agent, right? And which is the inhalational agent commonly used in children for induction purpose? It is sevoflurane. Why sevoflurane? Why? Because sevoflurane is sweet odor. It's having sweet odor. But one side effect of sevoflurane is also seen. That is what? Sevoflurane, whenever you are giving in a closed circuit, it will react with soda lime. In closed circuit, it will react with soda lime. Whenever you are using closed circuit, you will use low flow anesthesia, low flow of gases. So whenever you're using low flow of gases in closed circuit with soda lime, then what will happen? This sevoflurane can form a compound called as compound A, which is also called as olefin, which is a nephrotoxic compound. This is regarding what, guys? Sevoflurane. Now next coming to what? Desflurane. Now guys, regarding desflurane, what we need to remember, desflurane, what comes to your mind guys? Desflurane is an inhalational agent that can be used for daycare surgery. It is the inhalational agent used best, it is the best inhalational agent for cardiac surgery. But whether it is daycare or cardiac surgery, we are not using this desflurane. Even though it is best. Why it is best for daycare surgery? Why? Because desflurane is the least metabolized inhalational agent. Least metabolized inhalational agent. Right? But why we don't use? Why? Because for daycare surgery, it will cause airway irritation. Desflurane has the habit of causing airway irritation. Hence, for daycare surgery, instead of desflurane, what we choose guys? Instead of desflurane, we choose sevoflurane. Sevoflurane. Next, for cardiac surgery, desflurane is best. But again, desflurane, I told you, it is expensive. We are not using, and apart from being expensive, means desflurane itself is not expensive. The vaporizer of desflurane is expensive. So, instead of desflurane, for cardiac patients, we are using what guys? For cardiac patient, we are using isoflurane. Okay. So, even though you remember guys, the best agent for daycare and cardiac surgery is des, but most commonly for daycare, we are using sevoflurane, and for cardiac surgery, we are using what guys? Isoflurane. Okay. In hepatic surgery also, you can use desflurane. Why? Why? Because it is least metabolized in liver. Least metabolized inhalational agent in liver. Right? Next, desflurane can also be used for long duration surgeries. Why? Because it does not stay in the body. It is having least metabolism in the liver. So, that's regarding the desflurane. Coming to the last inhalational agent summary, that is nitrous oxide. The first thing about nitrous oxide that comes to your mind is the summary guys. In the summary, CNS, CVS, the most commonly used was what guys? ISO. Whereas for respiratory and muscle, halo. But for respiratory, even though halothane is good, but which is commonly used guys? Sevoflurane. Why? Because sevoflurane will reduce the airway resistance. Sevoflurane reduces the airway resistance. One extra point of sevoflurane that we need to remember is sevoflurane is best inhalational agent of choice for bronchial asthma. The second best is halothane. Second best is halothane. Even though halothane produces maximum bronchodilation, we use sevoflurane. The reason is what guys? The reason is sevoflurane decreases the airway resistance. It decreases the airway resistance much when compared to halothane. Okay. Next is nitrous oxide. Nitrous. Nitrous is stored in what color cylinders? Whenever you are writing nitrous, always remember guys, nitrous yani ki you need to remember nitrous is Neela. Neela. It is always stored in blue color cylinders. There is color coding given to the cylinders so that you should just look at the cylinder and identify what is the gas present in the cylinder. The next part of nitrous that we need to remember is nitrous is a very good analgesic agent. But it is having some contraindications, such as you should never give nitrous in pregnancy. Why? Why? Because it can cause teratogenic effects in the fetus, such as bone marrow deformities. Bone marrow deformities. Apart from that, what else we need to remember about nitrous? Nitrous is always avoided in closed loop surgeries. Why, sir? Why is nitrous avoided in closed loop surgery? So, apart from teratogenic effect, the last point of nitrous, we'll start from here. The last point of nitrous is avoided in closed loop surgeries. Closed loop surgeries such as intestinal obstruction surgery. Intestinal obstruction. In cases of intestinal obstruction, you never give nitrous. Why? Why don't you give nitrous? Why? Because in intestinal obstruction, one part of the intestine is obstructed, the other part will be dilated with or filled with air. Whenever you give nitrous, nitrous will expand the air containing cavities of the body that can lead to perforation. So nitrous is avoided in closed loop surgeries. Two more points of nitrous that we need to remember is, with nitrous you can see second gas effect, and with nitrous you can also see diffusion hypoxia. Second gas effect is what? Whenever you are giving nitrous, and with nitrous, remember you never give nitrous alone. Nitrous is always used as a carrier gas. As it is the least potent, it is always used as a carrier gas. So whenever you are using nitrous, you have to add one more inhalational agent. It could be halothane, sevoflurane, anything. Okay? So whenever you use nitrous with halothane or sevoflurane, nitrous will increase the concentration of other inhalational agent. Nitrous increases the concentration of other inhalational agent. That is second gas effect. Nitrous also causes diffusion hypoxia. Diffusion hypoxia. What is diffusion hypoxia, guys? It does not cause hypoxia during surgery, but after surgery. Remember, in the reversal phase of surgery, when the surgeon is done with the surgery, you need to stop the inhalational agents. Okay? When you are stopping the inhalational agents, you will be stopping halothane, you will be stopping nitrous, right? As you are stopping halothane and nitrous, you will continue to give oxygen to the patient. What you will see in this reversal phase, you will see there is a fall in oxygen saturation of the patient. Why? Because nitrous is having a better diffusion when compared to oxygen. It diffuses into the alveoli better. So what happens? There will be fall in oxygen saturation. So what we do, guys, at the end of the surgery to prevent diffusion hypoxia, we give 100% of oxygen. 100% of oxygen. That's regarding what, guys? That's regarding the diffusion hypoxia that we see with nitrous. Now coming to the summary of the general anesthetics. Okay? Now guys, look over here. Look over here. In this slide, what we are having is a patient is suffering with heart disease, which is the IV induction agent that we need to give, which is the muscle relaxant, and which is the inhalation agent. Okay? So basically remember, whenever a person is suffering with heart disease, when he is posted for surgery under general anesthesia, we have to give general anesthesia in 4 phases: pre-ops, induction, maintenance, reversal. Pre-oxygenation is done. Next is induction. In the induction phase, you have to give IV induction. In the induction phase, you also need to give muscle relaxant. And in the maintenance phase, you have to give inhalation agent. Remember, these is the main things. So these 3 drugs are important for general anesthesia: IV, muscle and inhalation agent. So if a person is suffering with heart disease, which is the IV induction agent that we need to give? The IV induction agent of choice for a person who is suffering with heart disease is what? Etomidate. E stands for etomidate. Why, sir? Why etomidate? Why? Because we have already discussed etomidate is the most cardiostable IV induction agent. Cardiostable meaning what? BP and pulse rate maintains. Next is what? If after giving the etomidate, next what we need to do? We need to give muscle relaxant to that patient. What is the muscle relaxant that we need to give to this patient who is suffering with heart disease? They are curiums, they are curoniums, they are scoline. Which one should be given, guys? Which is the cardiostable muscle relaxant that does not cause any changes in the BP and pulse rate? Heart. Cardiostable yani ki draw heart like this. When you draw heart like this, what? Remember, guys, when you draw a heart like this, V stands for it. Remember, if you just remove this part of the heart, it becomes V. So V stands for vecuronium. So muscle relaxant of choice for heart disease patient is vecuronium. Whereas the inhalation agent of choice for heart disease patient, the best is DES, but most commonly what we choose? Isoflurane. The best is desflurane, guys. Okay? Most commonly isoflurane. Asthmatic patient. If a patient is suffering with bronchial asthma, he is having severe V's and he's posted for some surgery under general anesthesia, which is the best IV induction agent that will cause good bronchodilation. It is ketamine. Which is a muscle relaxant? Any muscle relaxant could be given over here. Which is the inhalational agent of choice for asthma? The inhalational agent of choice for asthma is what, guys? It is sevoflurane. It is what, guys? Sevoflurane. The second best inhalational agent is what? Halothane. Halothane. Okay, sevoflurane and halothane both are causing bronchodilation, but sevoflurane decreases the airway resistance much, hence we are using sevoflurane for asthma. Okay, recent studies have proved. Next, if the patient is in shock, which is the best IV induction agent? Shock yani ki patient is in hypotension. The only IV induction agent that increases the BP that could be given in shock is what? It is ketamine. Okay? Muscle relaxant of choice in shock is what? Curiums and curoniums. There is one curonium that will increase the BP and heart rate. Remember, with the P of pancuronium, you have to remember RRR. R is rate. BP and pulse rate is increased. Second R is recovery, delayed recovery. Third R is renal. Pancuronium is contraindicated, renal failure. So remember, guys, muscle relaxant of choice in shock is what? Pancuronium. Okay? Next, in shock, which is the inhalational agent. So after giving this muscle relaxant, we have to give inhalational agent. The best is desflurane, but most commonly we choose isoflurane, same like heart disease. Okay? Daycare surgery. Daycare surgery, which is the IV induction agent of choice. I used to remember like this, guys. Pramod is posted for daycare surgery. Who's posted for daycare surgery? Pramod. I used to write like this. Pramod is posted for daycare surgery. Now what is this Pramod? Highlight on PMD. So in daycare surgery, the IV induction agent of choice is propofol. Why? Because less than 2 hours of duration, it is gone. The muscle relaxant of choice is mevaquerium. The shortest acting non-depolarizing is mevaquerium. Whereas the inhalational agent is desflurane. It is best. But again, it is causing airway irritation. Hence, most commonly what we choose for daycare surgery is we choose sevoflurane. Right? Last is neurosurgery. So, for neurosurgery, which is the IV induction agent of choice? For neurosurgery, the IV induction agent of choice is sodium thiopentone. The muscle relaxant NE. Whereas the inhalational agent of choice for neurosurgery is isoflurane. Whether for heart or whether for neurosurgery, most commonly we choose is what? Isoflurane. This slide is very, very important. Basically, the revision of your general anesthesia.